So guys, I know it's the last topic, so please bear with me. I know you guys are keen to go home. Okay, but I'll try and make it short and make it relevant. What I'm hoping to do today is basically to talk about the treatment of depression and anxiety in cardiovascular disease. Now, before I start, I think it's very important for me to tell you that I'm going to focus on the principles, because in terms of looking at individual antidepressants, you can always check the doses in your BNF, British National Formulary, or I don't know, whatever you use, you can check the doses. But I think it's very, very important to look at how do you treat depression and anxiety. Yeah, how do you treat anxiety and depression in the context of cardiovascular disease? And when we treat, what impact does it have on the depression? And what impact does it have on the cause of the cardiovascular disease? Okay. Now, whenever you talk about any treatment, I was hoping Dr. Alero would be here. You want to look at treatment from three main domains: primary, secondary, and tertiary. Okay. So with primary, we're talking about how do we prevent the onset of depression and anxiety. Secondary, we're looking at early detection of a psychiatric disorder, depression and anxiety. And I basically discussed that in my previous talk with the introduction. And then tertiary, when someone develops anxiety and depression in the context of a cardiovascular disease, how do you treat? Because this is very, very important. Now, what I have up there now is primary, promoting good mental health and prevention of depression and anxiety. And I do think we need to proactively be encouraging good mental health. So I would say for all of your patients with chronic physical illness, be it hypertension, be it diabetes, think and try and promote good mental health. Now, what I would suggest for those of your patients who maybe aren't that well educated, you can always talk about them having good exercise, because we know with exercise, it increases the natural opioid-peptides, which can help to improve mood. And we know that that is good for mild depression. So that kind of intervention is helpful. Advising people to exercise, eat right, rest, and take holidays. So I just want to know, in the last 1 year, how many people have taken a proper holiday? So I'm not talking about holidays where you travel to England and you walk all up and down the Oxford Street, because that is not a holiday. I'm talking about a holiday where you actually rest. How many people have taken a holiday in the last 1 year? Okay. Okay. But, I mean, that is one of the concerns. So you can imagine if you as professionals and you who know the importance of rest and good mental health, if you are not taking holidays, how much more are patients? So we need to be promoting these things. Now, the other thing I have here is bibliotherapy. Now, there's some very, very good, I call them self-help books. And I would encourage, for those of your patients who can afford it, if you go to Amazon, you've got a very good book there called Manage Your Mind by Butler and Hope. So if you do an Amazon search, you can get books like this, you understand? And basically what they do is just talk about good mental health, how to keep yourself relaxed, how to, you know, rest, good sleep hygiene and things like that. And there's also a good self-help website called www.livinglifetothefull.com. Now, this is an extremely fantastic website. It's not only good for mental health, but whenever you have a patient who you suspect has depressive symptoms or anxiety, I would strongly recommend this site. I would advise you that have a look at the website, go through it, so that when your patients with cardiovascular disease walk through the door, you can actually say, okay, look at this, what have you done? And the website is actually free. Okay. Now, the next thing we go to is secondary early detection. Now, for that, I've already spoken extensively, haven't I, about how to make a diagnosis of depressive episodes, of generalized anxiety disorder, panic disorder. So I'm not going to go through that. But what we're going to focus on now is tertiary treatment. So that means when our patients with cardiovascular disease develop depression and anxiety, how do we treat them? Now, in psychiatry, whenever we used to have our exams, member of Royal College of Psychiatry exams. Then we used to have the long case before we had the OSCEs. Whenever they asked you for how would you manage this patient, you know how in Nigeria, whenever they asked you for physical presentation of a disease, I was taught you start from the head and you work your way down to the toe. So in Nigeria, if they ask you chronic liver disease, you say something like fluffy hair, parotid enlargement, and you just go down, gynecomastia and stuff. So in psychiatry, whenever they used to ask us, we would say something along the lines of, I would like to manage this psychiatric patient suffering from bipolar disorder using a biopsychosocial model, considering the immediate, medium, and long-term needs, and with the context of a multidisciplinary team. Now, what that basically means is that for every patient you see with a psychological condition, you're looking at three main components. Biological. Biological is things like treatment. So, what's the treatment? What's the antidepressants? Or what's the treatment you're going to use to treat the anxiety? Psychological. So, psychological might be involve interventions like cognitive behavioral therapy. And by the way, the www.livinglifetothefull.com website teaches you basic cognitive behavioral therapy principles. So if you have a look at it, you could learn more. And social treatment. So what's their environment? What's their social support? Whom can they talk to? Whom can they confide in? All these are very, very important, particularly for depression and anxiety. Okay. Now for biological treatments, in terms of antidepressants, there are a number of classes we are going to discuss here. We've got SSRIs, and I'm just wondering, does anyone know what SSRIs are? Okay, so can I ask how many people have used an SSRI? So SSRI stands for Selective Serotonin Reuptake Inhibitor. And the basic principle is that in depression, what you have is you don't have enough neurotransmitter, so you don't have enough serotonin. So the basis is that if you prevent the serotonin from being taken up from the synapse, that means that the patient's depression will improve. They would sleep better, they would eat better, and their mood will be better. So that's the basic principle. Now, what are the type of SSRIs you use in your clinical practice? Pardon? Paroxetine. Yes. Okay, good. Pardon? Citalopram. Anything else that you use here? Okay. Pardon? Prozac, fluoxetine. Good old favorite. So in terms of SSRI, selective serotonin reuptake inhibitors, examples are sertraline, okay, fluoxetine, paroxetine, citalopram, to mention a few. Now, when I left Nigeria, the antidepressants of choice were tricyclic antidepressants. Now, how many of you remember what tricyclic antidepressants are? Because even people do neurology. Do people know what tricyclic antidepressants are? Okay. So, can you give me examples of tricyclic antidepressants? Amitriptyline, yes? Pardon? Imipramine, clomipramine. So, anything with the mins. There are also monoamine oxidase inhibitors, which I know they're used in Nigeria, but probably not as much. And then I put, it's actually NASA, so there are drugs like mirtazapine. Now, before I start telling you the effects of these broad classes of antidepressants, let me just remind you of some basic cardiovascular medicine. Because if you understand it, then it will give you an understanding of how these antidepressants might have an impact on the heart. So remember yesterday, Tokes was talking about the heart. Now he said that before contractions of the heart starts, that the sinoatrial node sets the tone of the contractility of the heart, isn't it? You have an electrical activity in the sinoatrial node. Then he said from the sinoatrial node, it then goes down to what? To the atrioventricular node. Then from there to what? Bundle of His. From bundle of His to what? No. Right and left bundles. And there from the Purkinje fibers. And there to the ventricular myocardium. You understand? So the electrical impulse needs to go through them. You understand? Now when you look at your ECG, you see things like PR intervals. Now the PR intervals basically tell you about your atrioventricular, about your atrial contraction. what happens there. You understand? Now, when you look at the QRS, there are two parts of the QRS. The first one is that time taken for the electrical impulse to traverse the atrioventricular node. Okay? The second part of that QRS interval is from the time from the bundle of His to the right and left bundles, and then to the Purkinje fibers, and then to the ventricular myocardium. You understand? Now, this is very, very, very important. You understand? Now, what we do know is that for some reason, tricyclic antidepressants, mainly amitriptyline, dosulepine, nortriptyline, imipramine, they prolong QRS interval. So basically, we are dealing with antidepressants, which in a normal heart, maybe you can get away with it. But can you imagine someone who's had a myocardial infarction and their heart has been ravaged such that their right and left bundle branch aren't working as good as they ought to? So this can actually lead to a heart block. It can lead to very poor conduction, and tricyclic antidepressants cause that. So as a general rule of thumb, I would say do not prescribe tricyclic antidepressants post myocardial infarction or with people with coronary artery disease. I would say it is a no-no. You understand? And I need to emphasize it in Nigeria because we use a lot of tricyclics. Okay? Now, the other thing is, tricyclics also have an anti-arrhythmic effect. So they can actually, if the heart tries to say, okay, there's no conduction via the AV node, via the bundle of His, if there's supposed to be idioventricular contraction, the tricyclic antidepressants can actually stop that conduction. So I've mentioned on 2 levels so far, it's extremely dangerous to use it post-MI or in coronary artery disease. So I would say even extend that to people who are smokers, who might be at risk. You understand? People with risk factors for coronary artery disease or a family history of sudden death. Okay. Now, the other thing to bear in mind is, remember we mentioned about the sinoatrial node. Now, we said the sinoatrial node basically sets the tone for the electrical impulse coming in, leading to contraction of the atrium and then to the ventricular. You understand? Now, what nerve controls that? What nerve controls how fast the sinoatrial node discharges? Vagus. Fantastic. Now, if you think about it, tricyclic antidepressants have anticholinergic function. So, because of that, what they do, because they're anticholinergic, they affect the vagal nerve from controlling how fast the sinoatrial node fires. So, as a result of that, you could argue that in a ravaged heart or something with cardiovascular disease, if you give something with an anticholinergic effect, it can affect, it means that the heart is running too fast. So there will be the risk of things like there could be the risk of things like atrial fibrillation or stuff. So we've mentioned about the QRS, prolonging QRS, leading to things like ventricular asystole or problems with conduction. We've mentioned that the tricyclics have an anticholinergic effect, which affects the vagal feedback on the sinoatrial node. The other thing that the tricyclic antidepressants can affect. Now, I know I've mentioned a lot of things, but I want to scare you guys to death so that when you think of cardiovascular disease, you remember not to use tricyclics. Have you guys heard of the QTC interval? QTC interval. I know it hasn't, I'm not sure if it's been mentioned here, but as a psychiatrist, a prolonged, for QTC intervals, that is corrected QTC interval, basically it's the accepted upper limit for females is 470 milliseconds. For males, it's 450 milliseconds. So if you go above that, that is trouble. Why is it trouble? Because QTC, although rarely, an increased QTC above normal can basically point to heart rhythm defects. So it could actually lead to things like ventricular fibrillations and ventricular tachycardia, which can be life-threatening. It causes a condition called torsade docoans, which is a life-threatening condition which can kill. So another reason for not giving tricyclic antidepressants is basically that if you give a tricyclic antidepressant, you can prolong QTC, particularly in a cardiovascular comprised patient. Are you guys clear about that? Okay. Pardon?
Are you trying to say that?
I would say do not use it as a rule of thumb. You want to avoid tricyclics. Okay. So the next question is, if tricyclics aren't good, what about SSRIs? Now, SSRIs are a very interesting group because what we do know from SSRIs, medication like fluoxetine and paroxetine, when we look at things like the heart rate, they actually lower the heart rate by about 9%, which in a cardiovascular comprised heart wouldn't be a bad thing, isn't it? And remember how I said that one of the problems in depression is that you have a surge of catecholamines, isn't it? Remember how we looked at how depression and anxiety can cause cardiovascular disease? We said that there's a surge in things like catecholamines. We said that there's an exaggerated things like platelet activated factor thromboglobulin. What we do know is that for drugs like fluoxetine and paroxetine, that these medications actually lower the heart rate by 9% and actually act as inhibitors to things like platelet activating factor and beta thromboglobulin. So from the heart point of view, if you are able to dislodge the platelets, then there is less risk for cardiovascular disease from a theoretical point of view. So I would say in patients post myocardial infarction or angina, the drugs of choice would be SSRIs. However, there is one however. For medication like citalopram and escitalopram, those medications, back in the day in the UK, we used to use them a lot. We used them a lot because, unlike the other antidepressants, they had less drug interactions with other medications. Latest research now is basically showing that for citalopram and escitalopram, they can actually cause prolonged QTC intervals, particularly in higher doses, just like tricyclics. Tricyclics in lower doses can affect the heart, and in overdoses and higher doses can affect the heart. You understand? Now, there's one interesting study which was published in the British Journal of Psychiatry by a guy called Roy Perlis, based in America. And in this study, they looked at 38,000 electronic records of patients. So you can imagine, very huge study. And what they did was they looked, okay, thanks. They looked at a number of antidepressants, about 11 antidepressants, and they looked at patients who had been on medication for 14 to 90 days, and then 2 weeks after that, they had ECGs. And what they basically found out was that for fluoxetine, paroxetine, venlafaxine, and for those medications, that there was no prolongation of QTC intervals. However, for citalopram and escitalopram, there was a significant, although it was a small, significant, statistically significant increase in QTC intervals. So as a rule of thumb, I would argue that you would need to exercise caution for giving citalopram or escitalopram in patients with cardiovascular diseases, particularly coronary artery disease. So as a rule of thumb, let me summarize what I've said. Tricyclics for coronary artery disease or cardiovascular compromised patients, I would say hell no. Try and avoid them. SSRIs are the drugs of choice, but try and avoid medication like citalopram and escitalopram. Does that make sense so far? Okay. Okay, now there's another drug called Nasrid. I call it NASA. It's a noradrenaline reuptake inhibitor, but it actually doesn't cause any serotonin reuptake. And it actually blocks 5-HT2 and 5-HT3 receptors, but it's a 5-HT1 agonist. Now, just ignore everything I've said. But the example of that antidepressant is called mirtazapine. How many people use mirtazapine? Has anyone heard of mirtazapine? Okay. Now, mirtazapine, it's a medication which you use at night, and it helps to sleep. So, more often than not, one of the advantages of the tricyclics is that they were very, very sedating. So, mirtazapine is an antidepressant you can give at night, and it is safe in cardiovascular compromised patients. So, again, let me summarize what I've said. Tricyclics bad in cardiovascular disease. SSRI is generally good, possibly with the exception of citalopram and escitalopram, which can prolong QTC. Okay? Okay. Now let's look at what are the principles of prescription when you prescribe an antidepressant. Okay, so you've got patients in your general practice who have cardiovascular disease. You've decided that they're depressed or they're anxious. Because remember, and these antidepressants I've mentioned, most of them are also indicated in anxiety disorders as well. Okay? Well, the principle is you start low. So with drugs like fluoxetine and paroxetine, you start at 20 milligrams. You might start lower for anxiety at a dose of 10 milligrams. And remember, for depression, your antidepressants do not start working until about 2 weeks after. So there's no point increasing your antidepressant until 2 weeks after, because that's when you begin to notice the onset. So you basically have to tell your patients, look, I'm going to start this medication, okay? This medication won't work until 2 weeks, so don't stop it before then. And even when it starts to work, don't stop taking the medication until I tell you. Are you guys clear with that? Okay. Now, the other thing is gradually increase. Now, some people, if you think you can go from 20 milligrams of fluoxetine to 60 milligrams of fluoxetine, which is the maximum dose of fluoxetine dose in 1 week, there's no point. For the reason I said, it takes 2 weeks to act. So it might be that you wait every 2 weeks before you increase. You understand? Now, if your patients are not responding to the antidepressants, or the depression is not responding to your antidepressants or the anxiety, the questions you need to ask is, are they taking the medication? You understand? Or what else is happening? Are they stressful events? Are they taking the right dose? And remember, our patients also take other medication as well. Okay? Now let's discuss side effects. So for people who are prescribing SSRIs, what are the side effects you tell the patients about? Hello? What are the common side effects of an SSRI?
Agitation.
Yup, particularly in younger patients. But Tokes does prescribe a lot of antidepressants. What do you tell your patients? Do you actually tell your patients about side effects that they might get on antidepressants? Because you should be telling them. If you don't tell them, they're not likely to take an antidepressant. But in terms of side effects, now think about it. What do SSRIs do? They prevent reuptake of serotonin. Now, there are 5-HT free receptors on the GI tract and also in a place called the vomiting center, which I believe is midbrain. Now, when serotonin binds to those receptors, one of the commonest side effects you have is nausea and vomiting. Okay? So nausea and vomiting. You've got to tell them there might be a risk that you might feel a bit sick or have a bit of tummy upset, but that often resolves after about a week because the receptors become used to it or desensitized. One. So nausea and vomiting. Other things like Toke said, you might have a bit of increase in anxiety when you take it. Now, that is particularly important for your anxious patients because if you give them a medication which, when they've taken in the first week, they feel anxious, they might not want to take it. But if you warn them that you might feel a bit anxious, but that would soon go, you understand? But the only thing to bear in mind for anxiety disorders is that the antidepressants might take a bit longer to work, like 6 weeks or so. So you mention that to them. And you have to mention about the risk of sexual dysfunction. I repeat, you have to mention about the risk of sexual dysfunction. Sometimes patients, when they have these antidepressants, the men might have erectile dysfunction or their libido might not be high, their sex drive might not be high, they might lose interest in sex. So that's something to discuss with them. But you've got to tell them that when they stop taking it, it will get better. And sometimes it's about negotiating with the patient about the importance of taking the antidepressants. Yes, you might have this risk, but sometimes when you are depressed, one's sex life isn't that great. And so in some cases, antidepressants can actually improve one's sex life. Now, of all the antidepressants, mirtazapine has the least propensity for causing sexual dysfunction. So if you are going to choose one antidepressant in a cardiovascular compromised patient, if the patient is saying, doctor, I'll take any drug, but I want a drug that gives me minimal risk of sexual dysfunction, I would choose mirtazapine. It helps with the sleep, and there's less. It doesn't mean it doesn't occur. It's about 25%, but for the other SSRIs, the risk of sexual dysfunction can be 30 to 70%. Okay? So always monitor for adverse events. So side effects. So remember, not all patients are going to tell you that they're anxious. Not all patients are going to tell you that they're having erectile dysfunction. So you've got to proactively ask. When you come and see them, when you prescribe it, monitor them and proactively ask for these side effects. Nausea and vomiting, sexual side effects, and all these kind of side effects. Now, let's look at a number of prognostic studies. So if I were to ask you, let's show of hands, what do you think, how effective do you think SSRIs would be for the treatment of depression in cardiovascular disease? How effective do you think they would be? Very effective? Do you think they will work? Hands up, how many people think that they would work in almost all cases? No sitting on the fence. So does that mean majority feel the antidepressants will not be effective for depression in cardiovascular disease? Will it be effective or will it not be effective? It will be effective. Okay. So my second question is, in cardiovascular disease, particularly coronary artery disease, given what I've told you about what antidepressants do, particularly SSRIs, I told you that SSRIs they inhibit platelet activating factor, they inhibit thromboglobulin, they cause an asymptomatic decrease in the heart rate by 9%. So looking at it on the surface, they're cardio-friendly. So if I ask you, what do you think about the effect of SSRIs on the cardiovascular outcomes? So a patient with coronary artery disease, if we treat them with an SSRI compared to placebo, would you expect the SSRI to have a better cardiovascular profile compared to the placebo? Yes. Okay. So the next question is, what does the research evidence tell us? Okay. So let me just refer you to a number of studies. Okay. So there's the SADAT study. So remember I told you that nowadays people like all these fancy name studies. So SADAT stands for sertraline. Okay. Sertraline is an antidepressant. Sertraline antidepressant heart attack randomized trial. That's a clever name, isn't it? Okay. Now, what the SADAT study showed, okay, and it was by Glassman and his colleagues, they looked at 369 patients who had post-myocardial infarction / stable angina. So these were patients after myocardial infarction or who had stable angina. And they compared them to those, and they all had depression. So some were on sertraline, some were on placebo. What the result did seem to show was that sertraline did do well in terms of depression, particularly if they had had a previous episode of depression, and particularly if their depression was severe. Though that was the trend of the patients who did well. Now, in terms of cardiovascular factors like ejection fraction, sertraline didn't do too badly. It didn't worsen the cardiovascular outcome. So that was the SADAT study. Now, the other study is called MIND-IT. Now, MIND-IT, they looked at, I think, about 300, just over 300 patients. Okay. They followed them up for about 18 months, and it was patients post-myocardial infarction. Now, MIND-IT stands for mirtazapine. So it stands for mirtazapine in depression intervention trial. Now, unfortunately, this study, for some reason, mirtazapine did not do any better than placebo for depressive symptoms. And in terms of cardiovascular events, so if you looked at things like mortality, if you looked at things like maybe risk of further heart attacks, it wasn't any better than placebo. So that's a surprise, isn't it? Okay? Now, CREATE, on the other hand, they looked at citalopram versus a psychological therapy called interpersonal therapy. Again, this study was conducted on patients post-myocardial infarction. And this study showed that citalopram was effective for depression, while the interpersonal therapy was not effective for depression. However, in terms of cardiovascular events, My understanding was there wasn't any difference between placebo and the antidepressants. Okay? Now, what of the Enrich-D study? The Enrich-D study stands for, let me see if I can remember it, enhancing recovery to improve coronary heart disease. Now, basically for this study, they looked at a psychological treatment called cognitive behavioral therapy. And they looked in, I think, if I remember, over 2,000 patients. So quite a large sample. And there they actually showed that CBT did improve depressive symptoms. Okay? So it did improve depressive symptoms and it improved social support. You know, I've been talking a lot about social support in patients with cardiovascular disease compared to placebo. However, in terms of the cardiovascular outcomes, there wasn't any difference. You understand? Now, final study is SADAT CHF. This CHF was a SADAT study done on people with congestive heart failure. So they were given sertraline, and basically for when patients had congestive heart failure and depression, so they looked at patients with congestive heart failure with depression who took sertraline versus patients with congestive heart failure with depression who didn't take any sertraline. And if you were to guess what the results were, what do you think the results were? Have a guess with what we've said so far. Do you think the sertraline was effective for depression? What do people think? Pardon? Just have a guess. I'll tell you the answer in a few minutes. But in this study, do you think the sertraline was effective for depression? Yes or no? Yes. Okay, who said no? Hands up if you said no. No? Okay. Okay, what about for the cardiovascular events? So looking at things like strokes, future myocardial infarction, risk of, risk of developing another heart attack. Who feels sertraline was effective in this study? Was it effective? Well, the answer was it was not effective for depression, and in terms of the cardiovascular events, it was just as bad as the placebo. So the question is, and this is why these studies are important, is, wait, hold on. We already know that when we look at trials, when we look at the indicators that should tell us that the cardiovascular event should improve with antidepressants, the studies, certainly for depression, some studies are showing that in cardiovascular disease, when we treat with antidepressants, the randomized control trials, sometimes they get better. But also an equal number of studies showing us that they don't respond. And in terms of cardiovascular events, most of the studies are showing us that antidepressants do not improve. So like Dr. Johnson said, I'm a pragmatic person. My advice would be still treat. It might be that the reason why we couldn't detect any difference was that these studies were underpowered. And if we had a larger sample of patients, we would improve things. You understand? So it might be that we need to do more studies with a huge number of people, more patients. Okay. Any questions so far? Okay, so let's think about psychosocial treatment. Okay? Now, for psychosocial treatment, obviously we've got cognitive behavioral therapy. Now, does anyone know anything about cognitive behavioral therapy? What it's about? What do you do? Pardon? No, I don't say psychiatry because GPs might have to use elements. Okay?
I think you try to get you try to know what the patient is thinking and see how you can help correct, some of the thought processes.
Fantastic. Man, I'm impressed. I'm very impressed. So you are correct. So cognitive behavioral therapy, the basic principle is that our thoughts affect our mood and our mood affects our behavior. You understand? So looking at it, I would say you guys are not going to be able to do cognitive behavioral therapy, but I've given you the tool. I've given you the website www.livinglifetothefull.com. It makes use of CBT principles. But when you look at a patient who is depressed, so let's take, remember I gave the example of Kasale Okereke. So Kasale Okereke is depressed because he developed a heart attack. One of the thoughts your patients might have is, well, because I've had this, they might be depressed because their thought pattern is, I had this heart attack because I stole my mother's yam when I was 6 years old. That might be the thought. Now you can imagine if you have a thought like that, that is due to the guilt because you are depressed. You have that thought, it makes you feel sad, and because you feel sad, you don't listen to Adebisi or Salawa Abeni. I like those two musicians quite well. You understand? And because you don't listen to Salawa Abeni, you get more depressed. And because you are more depressed, it reinforces that kind of negative thought pattern. So there are two things you can do. Okay? You can tell the patient, you look at your activities. Okay, so what did you used to do in the past? Well, I used to listen to Salawa Abeni. I like that. Molo Sagbo Salawa. You know, maybe you don't know that song. But that was a hit. Okay? And I also liked OBTK by Adebisi. So you could say, so how much of that are you doing? Well, I don't do it anymore. Why? Well, I just feel depressed. So why don't you listen to it? Now, the theory of CBT is that because thoughts are linked to behavior and to mood, the more he listens to Adebisi and Salawa Abeni, it means his mood would improve. And if his mood improves, he has less thoughts that I deserve this heart attack because I stole yams when I was 6 years old. Okay? So that's one thing you can do. That is called activity scheduling. Okay? Now, the other thing you can do is to challenge the thoughts. There's this thing called negative automatic thought. Because we know that when people are depressed, and I know I'm focusing on depressed, but it's just to talk about a principle. When people are depressed, yes, I'm going to talk about anxiety. When people are depressed, they have different types of thoughts. So there's this phenomenon called black or white thinking. So a patient would say, someone like Kasali would say, I'm either a totally good person or I'm an evil person. And because I had this heart attack, it means I'm an evil person. I deserved it. So what you do is you challenge him. You say, wait, Kasali, okay, give me an example of the most evil person in history. Now, when you ask for the most evil person in history, most people say Hitler. Some people say Babangida. Sorry, any Babangida. You understand? And then you say, okay, who is the best person in the world? Some, the Christians will say Jesus, the Muslims will say Prophet Muhammad. You understand? So you would say, okay, why is Hitler the most evil person? Did you kill anyone? No, I didn't kill anyone. So how can you say you're an evil person? Okay, so even though you are not like Jesus Christ, God forbid that you are like our Lord and personal Savior, Jesus Christ, who died for our sins. But you're not like Hitler. So where on the spectrum are you? You say, okay, maybe I'm in the middle. And then you start challenging those thoughts. And you challenge those thoughts by gathering evidence. Okay, what's the evidence that you're an evil person? What would your friends say? Imagine if you were in your friend's shoes. What would your friends say about you? Well, I'm sure Miss Sule, my fellow mechanic, will say I'm a nice person because I bought Eba for him. So if you bought Eba for your friend, will an evil person do that? Well, probably not. So you get more and more evidence and you challenge his negative automatic thoughts. So that is CBT in a nutshell. But please have a look at the website, www.livinglifetothefull.com. Okay, now let's go to progressive muscular relaxation techniques. Now, what do we do when our patients are anxious? Now, remember, when you tell patients about cardiovascular disease, we have to expect normal anxiety. And I would say there is no harm in encouraging our patients to do relaxation things. So you ask them, what makes you relax? For some people, they will say, when I listen to music, I'm relaxed. For some people, it might be when I pray in tongues, I'm relaxed. So you get the person to find out what relaxes them, and you tell them to carry that out. But on a more scientific level, there's this thing called progressive muscular relaxation and breathing techniques. Tokes use part of it. Now I'm going to need a chair to demonstrate this. Okay. Now the basic principle with relaxation techniques is that you can't be too extreme. You can't be in two extreme states at the same time. So you cannot be extremely anxious and relaxed at the same time. And that is called reciprocal inhibition. So what that means is, if I'm totally relaxed, I cannot be totally anxious. You understand? So what you do is, if the person, and this is something you can do in your GP surgery, you tell them to practice it every day. And this is not yoga. I'm a born-again Christian. I don't believe in yoga. But anyway, that's another thing. But this is what you do. You tell the person to sit down, okay? And you... Sorry. This is going to be difficult. I'm going to have to put the mic down to demonstrate this. But I will shout. Okay? So you tell them, ask the patient to sit down. And there are two things you need to do. There's the breathing. Okay? There's the breathing and there's the contraction of a muscle group. So what you do is you breathe, you ask the patient to, okay, watch what I do, breathe in, and then you hold it for about 4 seconds. 100, 200, 300, 400. Now breathe out slowly and relax. And then you progress, so you go from here, you go to the arms, okay, clench at your elbow joints, breathe in. 100, 200, 300, 400, and breathe out slowly and relax. And then you just, okay, that's enough. You then progress up from the fist up to the elbows, to the shoulders, and then you can start getting innovative the knees and the toes. And you just get the patient to practice it. Now, some patients will think it's totally stupid. How can I be doing that? I'm a busy man. I cannot be doing that. You understand? But my view is, I tell patients to do it all the time because the more you practice, the more you get better and better at doing it. And remember, even if a patient is in the middle of a panic attack, you can adapt it. So Tokes did a very good thing where when the patient had a panic attack, he got him to breathe in slowly and then to breathe out. So remember, you don't have to do the muscular, the contractions with the breathing. You can just do the breathing alone if that's easier. So does that make sense to people? Okay. So now that we've done progressive muscular relaxation, okay, let's look at bibliotherapy. Again, there are self-help books on the internet, Amazon. You can buy them, and you can buy them quite cheap. There is these books, they're called the Overcoming series. So I would encourage you guys, go and Google Overcoming. So Overcoming Depression by a guy called Paul Gilbert. Overcoming Anxiety by Helen Kennelly. Overcoming Low Self-Esteem by Melanie Fennell. Overcoming Chronic Pain. There's overcoming everything you can think of. Overcoming Serious. Overcoming Anxiety by, I think it's Helen Kennelly. Overcoming Depression by Paul Gilbert. And what the series you want is Overcoming Depression, and it's got a CBT self-help guide or a self-help CBT guide, something along the lines. If you look at it on Amazon, you can actually get knockdown prices. What's the name of that website where you can bid for things? eBay, sorry. I'm technophobic. But you might see it on eBay, Amazon, and you always get knockdown prices. I would say it's worth investing in it. I would say buy a couple, maybe Overcoming Depression, Overcoming Anxiety, and the Manage Your Mind book, so that you get used to the techniques. And what you just do is give the patients exercises. Okay? Now, whilst you are still there, there are also loads of self-help websites for bipolar disorder and for other conditions. I'm sure folks can tell you about a few other self-help websites. You use Mood Gym. Mood Gym. Yes. Is it www.mood.au? Yes. And it's free. Those two websites we told you about are free websites. Mood Gym. Okay, so now let's come to even more pragmatic things that you can do. Okay, thank you. Let's come to more pragmatic things. The question is, why don't you give a good explanation? The problem is, when people have cardiovascular disease, when you tell them, yes, what happened was you had a heart attack. The moment you mention heart attack, the patient is probably going to take 10% of the information in. So you've got to look at Tokes' approach. You've got to be there to contain them. Pause. You understand? Ask for them to come back. Ask them to bring family members. Write stuff down. Tell them to check stuff on the internet, stuff that you know is valid. Because the problem is sometimes people check wacky internet sites. You understand? All these things help. They help because the patient now has an understanding, a true understanding of the prognosis. So whenever you have your patients with cardiovascular disease, I would encourage, before you give them any information, ask, what do you think this means? What do you think will be the effect on your job and your family? What do you think you can do or not do as a result of your cardiovascular disease? That way, once you have the information, you can correct any false notions. So are you guys clear? So it's very, very important to explain. In Nigeria, I can't overemphasize this enough. The other point I have here is monitoring concordance to antidepressants and cardiovascular drugs. Now, let me just go back. In my previous slide, I did mention that there was that heart and soul study which showed that for patients who are depressed, they do not take their medication. I explained that to you. So I would expect that you've got to assume your patients will not take your medication. And I would say take that as a rule of thumb for all your patients with chronic disease. If your patient has high blood pressure, diabetes, a lot of the time your patients will not be taking their medication properly. So you've got to proactively ask. I know Dr. Johnson said he will ask, do you take your medication? But I think that's too vague, because the thing is, a patient might have taken their medication in the week before they were coming to visit you, and they might not have taken it at all. And that's why I always ask things like, in the last 3 months, how many doses of your medication have you missed? Because that assumes that you do understand that they will miss medication. I think you get more truthful answers. Or you would say, I know a lot of times it's difficult to take your medication. Have you missed any medication in the last few weeks? I think you've got a true answer. And if your patients tell you they're not taking their cardiovascular drugs, don't shout at them. Ask why. Why aren't you taking it? And sometimes you get things like side effects. And remember your antidepressants as well. Sometimes they will not take the antidepressants, particularly because of the sexual dysfunctions. But if you explain the side effects to them, if you warn them about it, then they're more likely to take the antidepressants. So I think these are pragmatic strategies you can use to help your patients. Okay, so the next question, I think it was Dr. Okong that asked me, when do you refer, was it you? Yes. When do you refer to a specialist? Now, again, I'm on dodgy waters here because I don't work in Nigeria. But what I would advise is, a lot of the time, you guys are going to have to be doing the management for depression and anxiety. And if what you guys have told me is correct, then referring to the psychiatrist is not easy. You understand? So I would say, if there are worsening symptoms, now I'm going to be vague about that. I would say worsening symptoms will depend on your level of expertise. You understand? So I would say you would have to read more about antidepressants, because 1 hour of a lecture can't give you all about it. But when you feel out of your depth, so a patient who is very, very depressed, who is not doing anything, a patient who is very, very anxious, and then you just feel, oh, Bobs, I don't feel manage this patient. If, that would differ from people's levels of experience. Then I would say, feel free to refer to the psychiatrist. Now, I will explain the difference between a psychiatrist and a psychologist, because someone mentioned that. Okay? Now, the next thing is suicidal ideations. Now, once patients start talking about suicide, and it's a different thing if someone says, you know what, this heart disease, I will be better off dead. Now, if someone tells you like that, explore. What do you mean? What do you mean by you'll be better off dead? So some patients have passive suicidal ideation. So they will say, I can't kill myself. I'm a born-again Christian, so I can't kill myself. However, if God took me to heaven tomorrow, I wouldn't mind. That's different from someone saying, you know what, I'll commit suicide. God will forgive me. That's different. So do a risk assessment, and then things like, how long have the suicidal thoughts been there? Have they been thinking about it? What makes it more likely that you commit suicide? So some people say, if I have this heart attack again, I'll commit suicide. Whilst others would say, what makes it more likely that I'll commit suicide is if I don't get better with the medication. So tease out, so that when you call your psychiatrist, if they come, then you've got a better case for saying why they need to be admitted. You understand? And sometimes, again, there's the whole issue of confidentiality. But if you get permission to speak to the family, I would argue in this condition, you should be able to break confidentiality. If someone is mentioning about killing themselves, then I'm sorry. You would have to do whatever it takes. So you might speak to a loved one, or, tell a loved one about it. Okay? Now I put others. I don't know why I put others there, but that was just in case anything came to mind. So just ignore that one. Second base, Ojare. So the next thing is the role of cardiac rehabilitation. Now, can I ask, is cardiac rehabilitation done here in Nigeria? Pardon? Okay. So I end my talk there. I'm only joking. Because the reason why I'm asking is that there's research to show that cardiac rehabilitation actually improves depressive symptoms. But it makes sense. Now, the problem with depression and anxiety is that research shows that when patients are depressed and anxious, they don't engage as well in cardiac rehabilitation. So you're saying we don't have any cardiac rehabilitation in Nigeria? Okay. Does anyone want to comment on that? Okay. So ladies and gentlemen, let me just summarize what I've said. So in summary, I've basically discussed about primary, secondary, and tertiary treatment of depression and anxiety within the context of a cardiovascular disease. I said we need to be proactive, primary-wise, so promoting good mental health in our patients. I mentioned the Manage Your Mind book by Gerald Butler and Hope. You understand? I mentioned the www.livinglifetothefull.com, which is good for primary prevention and treatment of depression. We mentioned secondary intervention, detecting early. We mentioned tertiary treatment. Now, for tertiary treatment, I told you that as a rule of thumb, for coronary artery disease, you want your SSRIs. Tricyclics, I know, due to prolongation of QTC interval, prolongation of QRS, worsening conduction problems, worsening heart blocks, and prolongation of QTC intervals. But I said for the SSRIs, sertraline good, fluoxetine good, paroxetine good. However, you might want to avoid citalopram and escitalopram. And I've also discussed psychosocial management and suggested self-help books. The other thing to bear in mind is when you've got a patient, say with cardiovascular disease, who has erythromycin, which we know can prolong QTC, if they are having grapefruit juice. Now, grapefruit juice is a cytochrome 3A4 inhibitor, which is a liver enzyme. Now, the cytochrome 3A4 breaks down the erythromycin. It's supposed to break down the erythromycin, which means if you inhibit that, that means you have elevated levels of erythromycin, and that can basically compromise can compromise someone who's cardiovascular compromised. So also remember, even though SSRIs are good, but if you are using an SSRI with a medication that prolongs QTC, because of its inhibition of certain liver enzymes, it could actually increase the chance that that medication can affect the heart. Are you guys clear with that? Okay? Any questions? Any questions? So you can all treat depression and anxiety. You will all treat... Yes?
I just want to know. Yes, sorry, psychiatry. Yes? I'm trying to remembering those approach.
Yes.
To use when you felt you are having
a panic attack.
panic attack.
Yes.
Assuming that from his questioning and very frank expression, it was incipient heart attack.
Okay.
Would you as a psychiatrist tell the patient a lie?
No.
What would you do?
So you're asking me if a patient is...
You were sitting there
Yes.
with drugs.
Yes.
And it was a panic attack.
Yes.
He was able to
Yes.
switch on the panic.
Yes.
Assuming that his own findings,
Yes.
that was an incipient
Yes.
You would have to be truthful. But you won't say, yeah, you're having a heart attack. You would say, Tokes is very good at it. So Tokes is a GP. GPs have the best consultation skills. But you might say something like, I'm really concerned with the symptoms you are describing. I'm really, really concerned. I do think that there's something going on and it might be a heart attack. However, again, whenever you break bad news, it's not just dropping them with the bomb, you got a heart attack. But yeah, I've got a heart attack. It's like, however, I do think that we can help you now if we get you to a hospital. So I'm going to call the ambulance. I'm going to do this. I'm going to do that. But remember, it's the way you break it. If you are calm, the patient will be calm with you. But if you are all panicky, then that doesn't bode well with the patient. Okay?
If the patient has had a previous attack,
Yes?
he knows, however, you can come.
Yes.
This is serious because the previous
Yep.
was falling, something was done. Would he consider that time you are taking to
Yes.
Well, it's a possibility, but again, for these things, you never know how it's going to come. But I would argue that generally as a rule of thumb, if you are calm, then your patients have more confidence in you than if you are agitated and if you lie. And if you lie and the patient finds out, they'll never trust you.
Please, can you go over the erythromycin, grapefruit, and
Okay. So someone wants me to go over the grapefruit again. So I just brought grapefruit up. Basic principle is that grapefruit juice, you understand, a lot of people think that juices and all these things have no effect. But we've got to think about some medications and food like grapefruit juice, they are potent inhibitors of cytochrome 3A4. Now, cytochrome 3A4 is what basically helps to break down drugs. So you don't have any, it's like a feedback mechanism so that the drugs don't have any excessive effect. So obviously, if it inhibits what will break down, if let's say you're using erythromycin or a cardiotoxic drug, which is broken down by that mechanism, then there's a risk of further cardiotoxicity. So always think about interactions. You should always think about interactions. What is taking? Tell me all your drugs and think, does this one prolong QTC interval? Does this one do this? Much like the way Dr. Johnson looked at digoxin. Understand?
I want to know the role of Lagatil and diazepam and Lezotan.
Okay. So I'm sorry I missed that out. So someone wants to know the role of Lagactil. Now, yes. Okay. Now, remember we're talking about cardiovascular disease. Now, chlorpromazine isn't particularly heart-friendly. Although, more often than not, for a chlorpromazine, you'll be using low doses. But the higher you go, there'll be effect. I would argue that you should avoid using chlorpromazine in a heart condition. Remember I told you that there are antidepressants like mirtazapine. So I hope that answers your question. I wouldn't use Lagactil in depression or in, I know it's used in Nigeria, but I wouldn't use it. You understand? Now, I do know sometimes for depression, we use augmentation strategy. So we might add an antipsychotic onto an antidepressant. But I would argue at the GP levels, that is specialist stuff. You shouldn't really be doing that. Now, would I use a benzodiazepine? Now, I would say it depends. The American approach is that for things like generalized anxiety disorder, you might put them on a benzodiazepine. And remember, the main risk is risk of addiction or dependence. And let's be honest, Nigerians, we are addicts. We are addicts like the you understand? I know some uncle that was using Lexotan and taking it like no man's business. So I would argue it's about controlling it. Now, sometimes it's about negotiating. So I would warn them about the risk of addiction. And the risk of addiction is reduced if you use a benzodiazepine with a longer half-life, like diazepam, rather than temazepam or lorazepam. And then you make it clear that we'll only use it for 2 weeks until the antidepressant kicks in if they've got an anxiety disorder, and then we take you off it. So short-term use, yes. For panic disorders, the Americans will use alprazolam, I think which Dr. Johnson alluded to, for panic disorders. In the UK, it's not in the guidelines. They don't advocate it for panic disorders. You understand? So, from a pragmatic point of view, Niger, as long as it's short-term use, but you've got to make it clear about the risk of addiction, which means that they will need to take more and more of the benzodiazepine to have the same effect if they stay on it, particularly if they stay on it for longer than 4 weeks. Does that answer your question? I know you like Lagactil, but I don't know. But in fairness, even in England, the old school doctors and the GPs, the GPs love chlorpromazine. But as a psychiatrist, I'm not a big fan of it. I hardly use it, except when I'm desperate. and certainly not for anxiety. Any more? Okay.
I also want to ask about a patient.
Okay. Please do.
The first time he has a violent attack was when they broke the news that the mom died. He was like mad person trying to beat up the wives and the children. Wasn't eating for some days and all that. After some time, he recovered. Maybe after 2 or 3 years, his sister died on a Sunday morning. Throughout that week, he was very violent and all that. In such a no family history of madness, yes,
Please
and
don't
also
use madness. Please. We will try to refrain using those words.
no family history of mental illness,
Okay.
and he doesn't have hypertension or any cardiac. So such a patient, um, what is the best approach? Because most times we start with Lagatil,
Okay.
diazepam, and all that.
Sorry. So on those events, he never has any long-term treatment. No, you just manage it supportively. Okay. So let's think about the franchise. Now, obviously, I don't know the patient, so I would take Dr. Kofo Abayomi's approach, which is I would like to see the patient and take a full extensive psychiatric history. There are 1,000,001 questions I can ask you, to tease out whether it's psychosis. Is there any loss of touch with reality? Are there delusions? Is he hallucinating? You understand? But remember, particularly in the African context, we have dissociative disorders. So dissociative disorders are things where, and you have them in the developing world, where you can have episodes where someone becomes very, very aggressive. Have you heard of this term, run amok?
Yeah.
Yes, run amok. Now, this amok term came from the Philippines, where they describe that, where there's a clear stressful event. They have periods where they're extremely violent and angry. It lasts for a few days or maybe a week or 2 weeks, and then it resolves on its own with very little treatment. That would fall under a dissociative disorder, and sometimes it's cultural bound. And you tend to get it in developing countries. So for that guy, if there are no clear-cut symptoms of psychosis other than the violence and the aggression, and there's a clear link with a stressful event, maybe just managing it, maybe discussing stress management, so things like anxiety, relaxation, these websites might be helpful. But you would need to tease out whether there are no psychotic symptoms. You understand? You might want to ask for a psychiatric opinion, and you've got to think about risk management. You understand? So if it happens the next time, when is it likely to happen? Would he recognize early warning symptoms? How would you manage? You understand? And with Nigeria, you also have to think, if someone is taken into a psychiatric hospital, that's stigmatization. But if it's the safe thing to do, then you've got to do. But I would argue that for that person, management of their anxiety would be helpful. Do they remember the events when they get better? Is it intentional or do they lose control? Yes. So it sounds to me like a dissociation, really. But like I said, you would really need to rule out psychosis. So you've got to ask the questions on delusions, hallucinations, whether they're thought disordered. So taking a good history would help. Well, you could ask from the patient and the relatives. Collateral history is very, very important.
See this from the patient.
Yeah.
No,
Yeah.
I will ask from both. Triangulate the data. Mm-hmm.
Commonly, you see some of these patients coming violently in the evening, around 10 p.m., 11 p.m., very violent in your clinic. You are not a favorite of chlorpromazine.
No, you can't use, if you want to use chlorpromazine in such a situation, I think that's been pragmatic. If it stops them from going into hospital, if you notice, I didn't say don't use. Okay. I think that makes sense. Okay. Sometimes you treat symptomatic. But it's also important to be sure about what the diagnosis is. And sometimes, from what you've said, that might not be a psychotic episode. Because Remember, culture-bound syndromes. That might be a dissociative disorder. It might be. So maybe asking for a second opinion or taking the history, because I would argue that that is grounds for asking for a second opinion. Or maybe the psychiatric could come and see. Okay, good.
Okay, fantastic. Any final questions?
No, sometimes we are having interaction with some of the psychiatrists. They were actually not happy with us. That most of the time when we see psychiatrists, most of the times when we see mental disorders, we just give them sedation and send it to them. That we don't even make efforts trying to manage them. I said, well, you might accuse us, but most of the time they don't do very well with us. But when they come to you, they do very well. From my own practical experience, that's why most of the patients find themselves coming to Aro or going to Yaba. Many of them will not do well. So we can only handle the acute phase and possibly send the referral to do. Yep.
All right, then. Final question.
Point noted.
A case of a medical student that knows about HIV. So this patient, this medical student, he doesn't shake hands with people. He doesn't sit where a patient sits, because when you ask him, he said he will get HIV. He doesn't eat where others eat. He doesn't use, it was just obvious that every other person noticed that. So he's such a student, as in he's aware of HIV. Yes. He thinks he can contact it anywhere, and it became a continuous sequence. So how are you going to?
Okay, good question. I actually answered. It's a bit similar to the patient you described, but I would disagree, except if medical education has fallen that drastically. You understand? But I think if he's a medical student, I would argue his medical knowledge should be a bit better. He will know he can't take it from, if he's not going to cut. Yeah. But the more reason why I would argue it is, like you said, a psychiatric condition. Now, the two differentials that come to my mind from what you said is, it could be hypochondriasis. And like I said, hypochondriasis is an excessive fear of developing an illness, which in his case might be AIDS. But sometimes, and another differential could be obsessive compulsive disorder. You understand? Where they've got contamination fears. So a careful history would tease it. But even if you can't tease it out, it doesn't really matter, because the treatment is rather the same. And in terms of conditions like that, they do well with cognitive behavioral therapy. But the question is, would you get a psychologist, which was what one of the doctors was saying to me. You could treat with an SSRI, you understand? But the gold standard of treatment, I would argue, would be cognitive behavioral therapy, or if you are desperate, SSRI. If you suspect it's OCD, the basic principle is, more often than not, it takes about 10 weeks to get better before you notice a response. And you've got to use higher doses of things like fluoxetine or sertraline. But as a psychologist, I would recommend CBT. But it's probably one of those two conditions.
Well, it's been a very long 2 days. Can we just say thank you to Dr. Akeem Sule for a fantastic presentation. It's been wonderful. We have enjoyed it as much as you have, perhaps even more as teachers. But it's been wonderful. And we look forward to seeing you again in March.